Thank you, Russ. And thank you, everybody, for the opportunity to be here and discuss these overlooked issues together with you. We've heard a lot about how to manage IBD over the last 3 days in this terrific conference, and we're going to be focusing on some additional issues here. Just to mention that some of the work that we're going to be presenting relates to work done through IBD Chorus, which is a program through the Crohn's and Colitis Foundation, and we'll be talking about how that relates. So I want to start with a case. This is a patient of mine, a 23-year-old screenwriter. About half of my patients in West Los Angeles are screenwriters. Or want to be, or think they are. Anyways, he had his Crohn's diagnosed at age 15, initially treated with prednisone, 5 ASAs, 6 mercaptopurine, was not effective. 2 years ago, he'd had surgery for a bowel obstruction. He didn't follow up because he felt well. And I'm seeing him now. I saw him a few weeks ago. He just returned from 6 months abroad. I asked what he did. He said, I smoked a lot of hookah. And we've heard from some of the prior talks that he might have had a good time doing that, but it probably wasn't very good for his Crohn's disease. He came to see me with 6 bloody bowel movements a day, right-sided abdominal cramping, stool tests were negative for infection, and he'd lost 15 pounds over the last 3 months. Some of his labs are shown. His hemoglobin was 9.8, platelets were elevated, inflammatory markers were up, and his albumin was a little bit low. I'm not going to show you here the colonoscopy, the imaging, the discussion that we had about starting medications and biologic therapies. I'm sure everybody here are experts in overseeing the management of such a patient. But what are the things that you might overlook? So let's talk about 5 things that one might overlook when thinking about a patient like this who's very sick, and there's some very obvious things that we want to focus on from a medical management standpoint, but also that we need to think about asking and screening for. So anemia. Millie touched on iron deficiency anemia a little bit earlier in the session today. Anemia is one of the top 10 outcomes that was identified in an outcome indicator, quality indicator evaluation of what is important for determining the success of treatment for patients. And so we recognize this within our CHORUS program and set about to try to wrap our heads around how do we think about anemia in inflammatory bowel disease. And this was an initiative that was led by Jason Howe, who developed and led the efforts to develop this anemia care pathway for inflammatory bowel disease. And by the way, this anemia care pathway for IBD is available as a CME, a free CME activity online. You can Google it and find it. And the idea is that screening for anemia is not something that we typically think about doing, but that screening for anemia in patients on a regular basis, or certainly targeting patients who you already see as anemic or who have fatigue, can send them down this care pathway. And that care pathway can identify patients who are anemic or who have iron deficiency, and that is defined by World Health Organization thresholds on the left, or patients who may be non-anemic but still have iron deficiency as defined by low ferritin on the right. And then just to focus on the left side of this care pathway, for patients who meet criteria for iron deficiency anemia, those who are anemic or have low ferritins, or patients who may have elevated ferritins due to an inflammatory response but have low transferrin saturations. These are patients that we need to think about because there are interventions that can be very helpful for them. In thinking about how we apply interventions to patients who are iron deficient with inflammatory bowel disease, recognizing the activity of IBD is really important. The reason it's important is because absorption of oral iron, in addition to being difficult for many patients to tolerate, actually can be physiologically difficult for patients who have active and elevated inflammation in their system. CRP actually downregulates the absorption of iron through various iron transport mechanisms, such that iron doesn't get actually absorbed from the enterocyte into the mainstream circulation when it's administered orally. And then the concept, once you've determined a course of action for treating with iron, is to follow up and to make sure that the iron intervention has actually worked by repeating the hemoglobin, repeating the iron studies, following up with the patient, and determining whether the intervention has been effective, not just in correcting the numbers, but also in identifying causes for a patient's underlying fatigue. Just to show this briefly, and you all have access to this, these are iron formulations that are part of the care pathway that are available that we should be aware of as gastroenterologists. If we're going to be talking and thinking about iron deficiency and repletion, we should understand that there are oral formulations, but also to recognize that, again, for patients with active disease or with GI intolerance, we need to also understand IV iron formulations that we may refer to a hematologist for, but also recognizing that there are differences and important factors that we might want to be aware of as gastroenterologists with respect to how to administer IV iron and when those might be appropriate.
Great, thanks Gil, and good morning everybody. The idea of these low-hanging fruit topics that we wanted to bring up is try to make it a little easier for you to engage with your patients and talk to them about it. Please do look at the slides that were provided, look at the care pathway that's published online at the Crohn's and Colitis Foundation for even CME activity or not. But we'll both freely admit that we don't know the right doses of oral or IV iron based on the different formulations. So you need some help, and you need to pull out that chart, and you need to use it. And that's the idea of putting these together, is to hopefully give you some guidance on not just checking a hemoglobin and telling your patient to go to the pharmacy and pick up whatever iron formulation they can find, or refer them to the pharmacist. This is our responsibility that we should understand and know either how to do ourselves or how to get help from our referral hematologist that we can work with. Well, I'm thrilled to see that issue number 4 is being talked about a lot more at this meeting, and I see coming up in this session we have Eva Sigathy and Lori Kiefer coming to talk to you about pain and how this is all tied together. But this is something that I really believe is overlooked and we need to focus on more and at least think about. I don't believe we can all be experts in how to diagnose and treat this, but we need to be experts in how to recognize the problem and how big of a problem it is with inflammatory bowel disease. And if you look at the incidence of depression over time, in addition to anxiety with patients diagnosed with IBD, that every year there are more patients who have depression, approximately an incidence of about 15% per year, and the longer you have IBD, that incidence rate, not just the cumulative prevalence, but the incidence rate goes up the longer you've been dealing with this chronic disease. And you can see that it gets up to over 50% when somebody's had this disease for 10 years or longer. And as you know, many of our patients have had this disease for a very long time. I know we know this when we see patients in clinic. We just have a hard time engaging with it because we're not exactly sure what to do with it, or we don't have the resources that we wish we had at the University of Pittsburgh or Mount Sinai Medical Center or other places that have great teams. We need to help each other at least identify these patients and think about addressing it with our patients and not ignoring it, because they're thinking about it when they come in. If you look at a recent systematic review, the overall prevalence of anxiety is about 20%. I mean, that's 1 in every 5 patients that we're seeing in clinic. That means in a busy clinic day, you're having a few patients every day come in who have a real problem that we're most often not addressing. It happens to be more Crohn's disease than ulcerative colitis, but certainly both are at risk. This is some nice work that came from Maria Bru's group in Miami, and you can see that there are a number of risk factors related to depression, but interestingly, the only ones that were statistically significant in the multivariate analysis were gender, so women more than men, but again, men are affected too, but disease activity levels. So another reason when we're leaving our patients smoldering without controlling their disease is something that can ultimately come for that is a more difficult quality of life and probably associated depression and anxiety. One can argue maybe there's a chicken and egg problem here, and maybe anxiety and depression leads to more active disease, but I would bet it's probably the other way around. And when we're thinking about the rapidity of which we want to get our patients under control, we're often talking about damage of disease leading to surgeries, complications over time. But please think about this as a complication of their inflammatory bowel disease, and the longer you let them go undiagnosed and untreated, the more difficult of a time they may have. I learned this from Eva and Lori yesterday because I felt like I needed to I needed help myself, and I wanted to help us as a field in understanding how we can do this quickly, because none of us are expert. Well, I'd say very few of us are expert in how to quickly identify anxiety and depression, and I'm thankful to learn about this tool that I've now become very interested in just over the past few days in thinking about screening my patients with 4 simple questions. The top 2 are related to anxiety, and the bottom 2 are related to depression. It gives you a very simple scoring system on the bottom. Again, I don't think we need to be expert in all of the very detailed ways that we need to get this from our patients or in all the ways that we need to treat our patients. But we all have access to psychologists either in the community or in our practices, psychiatrists at the hospital, social workers, even your nurses who can help and talk to our patients and make sure that we're not missing this. A very simple screening tool that I'm going to start using in my practice after this meeting to think about how I could make sure I don't miss these big problems with my patients. Another issue that has come up at this meeting and prior meetings, which I believe is really important, is this issue of sexual dysfunction. Again, something that we simply don't ask our patients about, but we know they're coming in with questions and problems, and we either don't think about it, we don't want to go there because we don't have enough time in clinic, we're not comfortable with how to bring it up. But this really is a real problem, and it was brought out last year at DDW by this nice work from a French group that talks about quality of life being a primary goal of our patients, and sexual dysfunction is a huge part of overall quality of life. So thinking about how sexual dysfunction compares in patients with IBD versus others, and including irritable bowel syndrome, and I'll show you the results of their 53-item questionnaire, that they tried to understand how big of a problem is this in our IBD patients, but as I'll also show you, and many of you are also seeing patients with IBS, and many of our patients with IBD also have IBS, that this problem's even compounded further. So when you look at the proportions of people who are saying that they have some type of sexual dysfunction, if you look at women with IBD, it's over half, men, it's nearly 20%. If you can look at erectile dysfunction in men with IBD, it's 43%. Then if you scroll down to IBS, and again, all of us are seeing these patients as well, you can see how incredibly high the numbers are in these patients who are really struggling with a problem that I would argue many of us, including myself, are ignoring in our patients and not addressing, and we need to talk to them about it. Gail, let me pass things back to you about nutrition.
Thanks, Corey. We heard a little bit about diet in the last talk, but what we want to focus on here is really not so much diet, but really nutrition. And nutrition was also identified as one of the top 10 quality outcome measures for patients with IBD in this evaluation undertaken a few years ago. But the issue with malnutrition is, what really is it? How do we understand it? How do we define it? And how do we treat it? So this was an area that was tackled as well as part of this program. And this was an initiative led by Carolyn Huang, which kind of took the same skeletal structure of that anemia care pathway and applied it in the realm of nutrition for a process for screening patients for malnutrition, understanding how to stratify them, assessing them, and making sure that there's appropriate evaluation and follow-up following some kind of intervention. And by the way, this is also available as a free CME activity online with a separate program both for physicians and for dietitians who may be interested in learning more about specifics around malnutrition and inflammatory bowel disease. And the core concept, I think, that's relevant to us as the practicing clinician who's identifying initially these patients and not overlooking this issue of malnutrition, is to first understand how can we screen for malnutrition. And there's a very basic, simple screening tool called the MUST, the Malnutrition Universal Screening Test. Some hospitals use this. So we modified this slightly to apply it to the IBD outpatient population, and it really looks at three very simple things that can be assessed in a first 30 seconds. A body mass index, which is probably already being done, understanding and recognizing that a very low body mass index, less than 18.5, is highly indicative of future morbidity. Second is weight loss in the past 3 to 6 months, specifically weight loss of more than 10% during that time period, and that was relevant in the patient case that we had discussed. And third is understanding whether the patient has active disease or not, and that's something that we're pretty good at identifying. Does the patient have active disease, or is the patient simply not eating, restricting what they're eating for whatever reason, and having poor oral intake? Combining these three factors can give you a quick score, and based on that score, a patient can be identified as low risk, moderate risk, or high risk for malnutrition. Through this care pathway, again, there's a flow from what happens there. Once a patient has been identified as being moderate or high risk, they go down the care pathway. And that care pathway involves further assessment, which are some specific labs looking at micronutrients, but ultimately referral to a dietitian and incorporating the dietitian into the practice, or having a referral dietitian that can help one identify, assess, and properly intervene on patients who have malnutrition. And what that dietitian referral accomplishes is taking beyond what we can really or are comfortable with in most cases in the gastroenterology setting, which is to do a comprehensive nutritional assessment, really taking a focused history and physical on malnutrition issues, understanding the diet that the patient is eating, what kinds of restrictions might a patient be incorporating accumulating in their diet that is limiting certain key nutrients from being part of their oral intake. And understanding which laboratory data are important to assess in order to identify those deficiencies and identify appropriate supplementation for them. And then that tailored intervention, which dietitians are so expert in, is the counseling, understanding food portions, liberalizing the diet, improving calories, vitamin and mineral supplementation, and when necessary, oral supplements, enteral nutrition, or even parenteral nutrition when it's necessary.
Thanks, Gil. The intent here is not to give you 3 or 4 new surveys that you have to hand out to every patient who comes in and then talk to them about depression and sexual dysfunction and make sure you follow the care pathways down. And we recognize that's completely impossible and that's not the intent at all. It's to really give tools so that you can focus on certain things in clinic. And the way our IBD course program works is we as a collaborative work on certain high importance topics all together and let individual practices work on one thing at a time or 2 things at a time, as opposed to trying to do everything in your practice, which we realize is impossible. But that's why these tools are available, is pick the things that you feel like you're not doing a great job at. The reason we picked anemia and nutrition was because we felt that we simply aren't good at it as gastroenterologists, and we need help, and we turn to experts to get advice and help in how to push it all forward. So that's really what the intent is here, is to give some tools that you can use in your practice. And again, these are either available in the slides that you have today or online as far as using these care pathways. The one thing I will ask you, and I've brought this up at the very first session of this meeting, is talking to your patients about what they're most concerned about. And we still consider this the most overlooked thing, because I do believe that many of our patients are coming in and you get through your agenda in the clinic visit, but they never got to really what was bothering them and what they came with. Somebody said to me once something that was incredibly important, I think about all the time, that for us, when you're in a clinic of 15 or 20 patients a day, one patient coming through is just a very small snapshot of your week. This is the most important part of your patient's probably month when they're coming to see you in the office, when they have a chronic disease and they need care and they need guidance, and not addressing what's most important to them, although it may not seem that important at the moment in the clinic, is going to be critically important for, I believe, their happiness and their trust in you. And again, I showed this earlier in the conference, but I wanted to bring it back, is just think about where your patients are on this hierarchy of need for their care in IBD. We're here talking about 4 to 6 month follow-up and endoscopy and making sure they have endoscopic and histologic healing. We're working at pushing their remission rates as high as we possibly can with combining drugs, but many of our patients certainly just aren't there yet. They simply need to feel better. They need to get out of the house without worrying about having an accident on their way to work. They need to think about how they don't have to run out of the classroom in the middle of class. They need to feel comfortable that they can even get on a plane to go on vacation somewhere. And we need to ask them what their biggest problems are so that we can help them and recognize that we have a focus that's critically important, but in a way that's our part. That's the part of the burden that we have to take on. But the burden that we also have to recognize is what the patients are experiencing every day. So as part of this program, we ask them one simple question, and out of all the tools that we've developed over the past few years, as far as the IBD course program, the one that I have found has really transformed my clinic office visits is simply asking them what's the #1 concern or goal related to this office visit, and point them in the direction that it doesn't have to be about their abdominal pain, diarrhea, or rectal bleeding. It could be anything related to their disease state or concern that they have that they even think is related to it, and make sure that we simply address it and ask them about it. We ask them about it at the beginning of the visit, not the end when they're grabbing onto their coat, walking out, you're getting prepared for the next visit and to finish up your note, and have them say at the very end something like, I have a vacation day every time I have an infliximab infusion. I don't have any vacation because of this. We learned that and changed him to home infusions, which was the biggest impact on his quality of life that I possibly could have made at that visit. A patient told us that they have a wedding coming up and they simply need to be off of prednisone, whatever we possibly have to do, so that she doesn't feel like she's bloated on prednisone during her wedding. Again, incredibly important to her at that moment, and I would agree, always important. A patient of mine who came and was completely well, this would have been a 2-minute office visit, when I said, how are you feeling? She said fine, her meds were tuned up, her trough levels were perfect, but instead we spent the entire time talking about the fact that she was honestly concerned that she might marry this gentleman she was dating who also has Crohn's disease, because in her mind, she thought they never could have children and it wasn't safe. And I don't know that ever would have come out unless we pointed her in the right direction. You could see some others here about worried about affording medications. A patients come up all the time who are in college, who are going abroad, and you need to think about that and anticipate it before the week before they go away and say, I'm sure I can get my Remicade fusions in Africa, right? And then you have to figure out at the last minute. So again, if you take anything from this, there are tools available to help us with some of these very important things to our patients that will make them feel better every day, and simply ask your patients what they really need out of that visit, and I promise you would have made it a more important visit for them at that moment. So thank you very much.